being here. So today we're going to be talking with Randy Baker from MedCall. Randy's been somebody that we've worked closely with through this process as COVID began. I think it was back in April when we first started connecting Randy. Randy does tele-emergent care, which is really high level, very in-depth medical care, and does a great job. Maybe, Randy, would you mind just telling everybody a little bit about MedCall and your background, what it is that you do?
Sure. I had friends in Washington, D.C., so I had kind of a front row on the discussions and debate about the Affordable Health Care Act, and just saw an opportunity that it seemed to me if you could figure out a way to leverage technology to increase capacity and capacity for the provider network and increase access to folks to better health care, it just made all the sense in the world to me. So we fooled around in traditional style telemedicine for a while and just identified some concerns that we had with that and the efficacy rate. And ultimately, we decided on a little bit of a different model in that we would build a provider network specifically for this type of care. We decided to hire only physicians that are board certified in emergency medicine. We own our own medical practice, so we have a very structured practice with a chief medical director, senior medical directors underneath them. And so far, knock on wood, it's been a highly effective model. We don't do callbacks or we don't do appointments. If you're suffering from an acute medical event, you basically push a button, dial a number, and we connect you with an emergency physician. So we've been doing that since about early 2016, and it's been a very good model.
And you have quickly moved into the COVID response and COVID service model. Can you tell us a little bit about the reason why and what it is that you're doing?
Well, we did, quite frankly, because we have, all of our physicians will still pull time in the ER in the various states where they're licensed in, and some of them actually move around from state to state as well. And when we started getting, frontline intelligence from these guys about what their experiences were and what they were seeing, and saw the value in trying to identify these risk factors early to try to keep people from getting to a point where they wound up in the ER or wound up on a ventilator. We just saw that as an opportunity to leverage that asset which we had, which was ER physicians, and partner them with a testing program.
Okay. So let me just jump real quick. Let's talk a little bit about, just kind of give an overview of the situation, where we're at, and the types of tests, and we'll get into a little bit more about some of the things that you've been doing that I think we can apply to ministries, whether they're a church or a school or a camp or a college. So, Randy, you were going to tell us all about, I'm controlling this, so here we go. Tell us, what is COVID? Because it's tough because there's some misconceptions and, it's really challenging. So I did ask you just to kind of go over this a little bit.
Sure. I basically stole this. I didn't write it myself, but, this is right from the CDC. Coronavirus is a very common virus. What a novel virus is, it's a new, previously undisclosed or unidentified virus. And there's been lots of things out there about why is it called COVID 2019. It's simply because the disease originated in 2019. That's where that comes from. So there's no, mystery behind that. I think one of the greatest misconceptions that's out there, and we hear it from people all the time, is that, somehow this virus has become politicized, and everybody's trying to look at the statistics of, how many people died and what did they die from and what were the multiple reasons that they died. Here's what I can tell you from the guys that work this virus on the front lines. This is not the flu. This is not like the flu. This is fundamentally different from the flu. And even though a lot of people have this virus that are asymptomatic, there's more and more research out there now. In the beginning, everybody thought it was a respiratory illness, but now there's been more research done. It's really more of a vascular disease. And what that means is this virus actually attacks the tissue within your body. And so the scary thing to us that we see today is even people who had this disease and were asymptomatic, there's a high likelihood that there will be long-term health issues left in the wake of this virus. So just, want to caution everybody, it's a nasty, it's just a nasty virus. Even when it's asymptomatic, that's my 2 cents on it.
No, it's, a lot of people say it's a conspiracy, but it have to be a worldwide conspiracy at this point. It's just, it's something we all need to take seriously. We need to protect the people that we've been entrusted to care for, whatever our ministry is. And so, no, we are taking it seriously. We talked a little bit about some of the symptoms. What's the difference between these symptoms and we're getting through summer and, we're going to hit flu season pretty soon. And that's something that, we're looking at. Is there something different with the COVID symptoms than typical flu symptoms?
Well, I think that's a big concern in the medical community because it is going to converge with flu season. There are a lot of similarities between the two. You can go down fever, chills, cough, shortness of breath, fatigue, all the things that are typical with the flu. But when these two things do converge, it's going to be incredibly important. If you do come down with these symptoms, you really need to determine if you have been infected with COVID or if it's the flu. It's critically important that we know the difference. Some people die from the flu, no doubt. But you still, in order to protect yourself, you're going to need to know which one that you have. And these, the symptoms have sort of evolved a little bit over time from the CDC. They came out in the beginning, there was like 4 primary symptoms. Then they started adding a symptom, and you see things that they start talking now about COVID toes and these weird things that happen to people. The reason for that is that it's a morphing virus. It has a unique way to sort of reinvent itself in other in other forms. So that's why you see the constantly updating information. And frankly, the CDC gets they get criticized a lot for putting out conflicting information. They put out one thing one day, and then 3 months later they put out something else. And the reason is because the virus changes in the way it presents itself. It wasn't that long ago, everybody thought that the virus entered through your eyes. There was an argument about don't wear a mask because people are fiddling with it all the time. And then you get the virus is on your fingers and it goes through your eyes. Is it airborne? Is it not airborne? And then most recently, the most current research shows that the virus may actually enter through your nose. It really is a moving target.
Okay. So as we're entering into flu season, which it's 100 degrees out here in California, it is right around the corner. We need to prepare for it now, especially as our schools are getting ready to reopen in the next few weeks. And as hopefully we're going to be able to resume church services as well. So, but is there anything specific that would be a warning sign that something is COVID-19 versus the flu?
We obviously have a lot of people calling in here. The most common thing now that we hear is people who lost a taste of, or lost their taste or smell. 2 months ago, didn't exist. And now we probably have a third of the people call in, and that's the first symptom they see is a loss of taste and smell. And we see that's primarily in young people, in people under 40, and a lot of the college kids. That's one of the first things they notice, which again is, in some level makes no sense, but it sort of is what it is.
So they may be asymptomatic in every other area, but just lose their taste and smell. But if you're not really feeling the aches, you're not getting the fever, you're not necessarily going to go get tested, but you're still going to be spreading it, is what you're saying.
Yeah, absolutely. And the people that have the loss of taste and smell typically don't have a fever. And so once again, that, almost everywhere you go, which I was with my wife at the hospital yesterday, everywhere you go there, and the hotel we stayed at, they're sticking the thermometer on your forehead to check your temperature. And a lot of these other symptoms that have exposed themselves in the last, 60 days, these people don't have a fever.
Mm. So let me jump on that for just a second then. What about the recommendations that we're hearing about taking temperatures as you're entering the church or school or campus or whatever it might be?
I mean, there's certainly nothing wrong with doing that. It's sort of, the no harm, no foul rule. There's nothing wrong with doing that, but you just can't rely on that. I mean, it's just,
Sure.
it would be an ineffective strategy for that to be your decision point.
Okay. For that alone, right? It's everything, and it's a comprehensive plan and a comprehensive strategy. So, okay, so now we're looking at some of the symptoms. If we watch the news, if we read the paper, we're hearing about them. And again, we will share the recording of this webinar along with the slide deck to everybody. It'll probably go out tomorrow morning, middle of the day tomorrow. So it'll go out to you, so you have this reference as well. Okay, big question. When to get tested? There's a controversy.
Yeah, and this is a big one. In the beginning, we were told that it was only appropriate for first responders and frontline people to get tested, and there was a reason for that, and that everybody was concerned about the shortage of tests, so we wanted to make sure those people were taken care of first. And then I think, you guys are aware because we did one for you too. We were actually the first company in the United States to go online live with an artificial intelligence screener. And at that time, the way you determine who gets tested was you go through the screening process and we try to identify, at least 2 or potentially 3 of the symptoms that were, that were the primary focus at that point in time. And so if you saw those symptoms, then you got tested. Then we entered a place where it was, everybody's got to get tested. We got to test 300 million people in the United States. I mean, everybody quickly realized that, that didn't make any sense either, because you couldn't do that. So then it got to be, if you have symptoms or if you've been exposed, you need to get tested. So I'm not here to tell you there's any right or wrong answer. But when the CDC came out and basically said, everybody doesn't need to get tested, that created an unnecessary controversy. The bottom line is, if you think you've been exposed to the virus, if you find that you have been in close proximity to someone that tested positive to the virus, if you displayed any symptoms that were listed on the previous screens, the reality is you should get tested. That's the determining factor. If you're perfectly healthy and you've been quarantined in your house, you haven't had any human contact in the last 60 days, then you probably don't need to get tested. But if you've been in an environment, that probably makes good sense. But again, let me say the best way to protect yourself from getting exposed in those situations is to practice good hygiene, to try to practice the social, we call it physical distancing, not social distancing, but it's physical distancing. And if you can't maintain that, then it is best to wear a mask, especially now that we know that the virus potentially enters through the nose. That best advice is just try to, don't congregate in a small enclosed area with a lot of people having face-to-face contact. I tell my children who are now going back at school, just try to avoid those direct face-to-face conversations and contact with somebody. If you're going to talk to somebody directly, stay a little bit further apart.
Okay, so we're going to talk a little bit about the kinds of tests as well. So what are the difference between the 3 of them?
Big misconception out there with tests. But the tests really fall in 3 categories. The first test is an antigen test, which, like it says, looks for proteins that make up the virus to help determine if a person has an active infection. But this test has flaws in it. Just because this test at a given moment in time tests positive or negative, most clinical providers would tell you that in order to be certain, you got to follow up with a PCR test. A PCR test is a more effective test, but either one of these two tests are used specifically to find out if you have an active COVID infection in your body at that moment in time. That's what those tests are designed for. So again, if the antigen is on the front line, oftentimes those tests, in order to have a good result, you have to follow with a PCR test. And those tests are primarily the nasal swabs that you see. We'll talk about that more in a minute, but you see the people on TV getting a little nasal swab. That's either an antigen or a PCR test. Then the antibody test is a different type of test, and this is a full blood draw test. We've seen people out there saying they have a test where you could prick your finger and test for the antibodies. I haven't seen a single finger prick test that I think is effective and worth doing. Well, the antibody test will let you know is, did you at some point prior in time have COVID-19 and your body's natural response is building up the antibodies? So once again, tests are a commodity. They're out there in multiple different ways, doing nasal swabs, there's saliva tests, there's the sputum test, which is more of a spitting in a, coughing and spitting in a cup, the finger pricks, the full blood draws. I mean, these things are all over the place. Now we're hearing, you've got the rapid test. We can do a test and get results in 5 minutes. I can only tell you our perspective and based on our experience and where we are today. We represent probably a dozen different labs and tests. If people are adamant they want one test or another, we try to facilitate that. What our experience has been, we're more married to the PCR test and a test that's called the sputum test. We like it because it's a test where you can literally spit in a specimen cup, you drop it in a FedEx, you send it, we get the results back in 24 hours. It's a highly reliable test as far as the accuracy, the sensitivity of that test. We just happen to like that one. It's pretty hard to mess up. One of the problems we found early on in the nasal swab, if you have a nurse or someone who's administering the test to you, great. The self-administered test or the take-it-home test is a very uncomfortable test, and most people will not do it right because it's too uncomfortable. So, we just for our purposes, we will provide any test anybody wants. We happen to like the sputum test, which is a DNA-based test. It's running a FDA certified CLIA lab that specifically builds off of DNA models.
Okay, so let me ask you about some of the tests that we've heard about and the test results that we've heard about, where somebody has said, hey, I got tested, I knew I had it, and the test that I received, I found out later on that it's only 60% accurate. Or, my wife and I, we both, could have sworn that she had COVID, and when early on in the year we went and got tested, then she still thinks she had it, but her test was only, I think, 60% positive when she was looking for the antibody test. Have these tests improved over the past few months? How accurate are they now?
It depends on the test. I mean, remember how the government responded to the test. They had what's called an emergency use authorization. So you've got everybody from veterinarian labs to Tom and Harry's labs to Quest and LabCorp, but anybody that could come up with a lab in a quick period of time, show any sort of evidence on the sensitivity of that test, they got what was called an emergency use authorization. And so that's why you literally have, even the CDC had issues where they ran a bunch of tests and they got a bunch of false positives and false negatives. A lot of those test companies that came out early, they've been shut down, officially been shut down. You can still go buy some tests on the black market, that are very inexpensive tests. But even some of the tests that are still out there, their sensitivity is 80%. And all we can do is provide the information. We have some clients that those tests are a little bit less expensive, not a lot less expensive, but they're a little bit less expensive. And those are the ones they want to do. We make them sign a waiver and we do it. So we make sure they understand there's a 20% chance that these tests are going to be wrong. And if you're comfortable with that, then that's okay. But I wouldn't even consider, we wouldn't participate in a test that was less than 80%, and we don't do those without a waiver.
And the PCR test is, what's the percent on that?
Well, the sputum test that we use is basically 99.9%.
Okay, so that's, okay, I got you.
And just so you know, when we say that, those are peer-reviewed tests. So this test was peer-reviewed by labs at Yale. And so anytime you're looking at a test, if you want to find out, what the rating of that test is, you can always ask for the clinical data. And as long as it's been peer-reviewed by a third party, and you can see their sensitivity, then you can have a high degree of confidence that it's a good test. Because it was FDA approved means nothing. Because it was an EAU means nothing. The sputum test that we use was also approved under the EAU or EUA, but it's a FDA certified CLIA lab. So that's a little bit different. They're held to a different standard because they do DNA testing. So, highly reliable test.
Okay. When do you think the testing really improved? Do you think it's just something really that has kind of kicked in about the past month or so?
Not necessarily. I mean, I think when LabCorp and Quest, when those two guys, when they came out with their first test, it was a really good test. It was a very good test. So I won't say that the quality of the test has improved, but they certainly weeded out the tests that never should have been approved in the very beginning. And anytime you're trying to, all of us hate the bureaucracy of a government and trying to go through all the processes it takes to get anything done. But when you bypass a lot of those typical requirements for something like doing the COVID test, you're going to have issues pop up that, hopefully they've all been weeded out at this point. Now, the antibody test is a little bit of a different test. I think that antibody test is going to continue to kind of track that virus as it morphs itself. There's been 2 documented cases that I'm aware of where they absolutely certain someone had coronavirus or COVID-19. They completely recovered where the virus was gone, and they got infected a second time. So there are only 2 cases that I know of. But there's so many underlying possibilities with that. Was it somebody who has a compromised immune system that just doesn't have the ability to build up antibodies? I don't know, but that's another consideration.
Okay, but this isn't the type of thing like when you were a kid and everybody had the chicken pox. You said, okay, everybody go over to the same place and everybody gets it because you want them to get it. And because then they're also going to have the antibodies, and then they aren't going to catch it again. We just want to be clear on that. And I'm asking you, Randy, to just weigh in on that.
Well, full disclosure, I've made that comment. I've made that comment myself that I think maybe we just all should go get it. Let's get the herd immunity and be done with it. I have to tell you, my view on that has changed a little bit in so much as I do not want to get it, period. No, it's probably going to happen, but I'm 61 years old. I'm entering into the danger zone. So I don't want to take that risk.
Yeah, I'm with you. So we want to avoid it. And part of that is testing people on a regular basis. In many areas, we're required to test here in California. So let's talk a little bit more about kind of MedCall Campus. Can you explain this a little bit for us, Randy?
Yes. So when we all of this first came about, and our business is largely in the workers' comp business, but we have so we have a lot of employers that laid their employees off, and so we were everybody's trying to come up with a plan. How do I bring my folks back to work in a safe environment? You know, it's great to go in and sterilize everything and spray Clorox everywhere, clean all your facilities. But the reality is we say that's good until the first person sneezes on it. Then all that effort was gone, because it just doesn't, it's not a barrier there. And so we built a program similar to this for employers. And then we got contacted by a company who actually writes a lot of work comp insurance for colleges and universities across the country. And they asked us if we would work with them to try to develop a safe return to work program. So, you know, you can go through this chart. I will tell you, I don't have a single client who follows it exactly the way we designed it. But this is meant to be a guide. And what we see in the nutshell version is, if you're you know, a school or a camp or a college or a church or whatever business you're in, and you're trying to bring your folks back in, the most important thing you can do, in our opinion, is establish a baseline. You have to have a baseline to start and make sure everybody's on a level playing field. And the only way that we know to do that, and the way we did it with Davidson College, is we tested every student, every faculty and staff member, and we got those results back 48 hours, you know, give or take 18 hours before those folks came back on campus. So we knew all the faculty and staff that were on campus were COVID free. We knew that all of the students before they moved to the dorm were COVID free. 100%.
Randy, back up just a little bit, okay? Let's go from the beginning. Davidson College contacted you. You were in touch with Davidson College, and they said, okay, we want to bring our students back.
Right.
And so what did you do first?
Well, you know, first of all, it was an agonizing process, and we understand, because you've got 2,000 or 2,100 faculty and staff, and you're talking about testing them all. That's a financial commitment. And so the first thing that had to happen was they had to come to terms with the financial commitment, right? We've talked about random testing. We talked about, kind of sporadic testing. Let's just do the faculty and staff. Let's tell all the students they got to go get tested before they come back. And of course, when you're talking to a client, you want to do whatever they want you to do. But at the end of the day, you got to bring them back and say, well, why are you bringing all these students back to campus? Like, why? Why are you doing it? Well, the reality is it's based on economics. It's the economics of making sure you got a business to run. Your business is educating students, and they're, $60,000 to $70,000 a year. So you're saying you're bringing them back for economic reasons, but yet you're wrestling with yourself over the economics of testing, right? So what happens if you don't test them, or you random test them and you bring them in, you have an outbreak right after everybody moves back in, you're gonna be sending them home. And so they ultimately, on their own, came to the conclusion that the only thing to do was let's make sure that every person who comes on this campus on day one is COVID free. And so that's how we started. And in the first 2 weeks of classes, we tested about 400 students a day. So we basically retested the student population week one. Then we retested the population in week two. And then we brought in another testing company just because we wanted to give them that diversity, to bring in another testing company for week three. And the result of that was the first 3 weeks of school, we only had one person test positive. And that person had gone home on an approved visit for a family emergency. He came back on campus before they tested him, and he tested positive the next day. The only other outbreak that the Davidson has had is with their baseball team. They had 19 members of their baseball team that went off campus for an activity, and they tested them all the next day, and they all tested positive. But because of the way they were doing it, they were able to control it without having a community spread within the campus.
Wait, the whole baseball team tested positive?
19 students on the baseball team.
Wow. Okay, now compare that with Duke University. Duke University,
which we didn't do, we didn't personally do as our company, but they followed the same procedure. I think it was the first week of August, they ran 17,000 tests on their students and staff and faculty, and they had a 0.3% positive rate. They had 46 cases of COVID. And then, just a few miles down the street at UNC, which has been all over the newspaper, which they had no clear defined strategy. During that same time period, UNC had 900 COVID cases. And they basically shut down and sent the students away. And so if you don't have a strategy, or you don't have a good strategy, I'm not sure what they expected to happen.
Okay. So tell us more about what MedCall's program is. If I'm a church, if I'm a school, if I'm a camp, if I'm a college, and what is the service that's provided by MedCall for COVID testing?
I'm glad to use the word service, because testing is a commodity, right? So there are tests available everywhere. You can probably go in your local community and get a free test when they're available. There's some places you can order an in-home test kit. I can tell you what our service is. Our service is to help bring you a comprehensive strategy. We have a medical practice that issues the orders for all the tests, because you need a prescription for the test. There consistency in the testing, and I think you said that. I guess everybody on this call is basically kind of an employer, right? So you're an employer administration, so you have both employees and you have, we'll call them consumers, which would be your students or your clients or customers. So what we urge you to do is have everybody do the same thing, right? Doesn't matter if it's MedCall or if it's another test company, but pick a test, pick a clinical provider. There's some companies out there that'll have a rubber stamp. So they have a doctor who'll sit there and just stamp all of your test orders and send them out. But that doctor assumes no liability and no responsibility for that test. He's not going to consult with your students. He's not going to follow up on the test results. They're just rubber stamping them out. When we order tests, our clinical practice group takes ownership of that test and that patient. When the results come back, if they're negative, we're going to shoot you an email, high five, great news, you're negative. If you test positive, you're going to get a call, and we're going to immediately connect you with one of our ER physicians, because we want to find out if there's any other risk factors that are available there. Remember, most of our clients are work comp clients. I'm not sure exactly how the laws are in California, but a lot of states, based on pressure from the healthcare companies, are trying to subrogate this risk of employee COVID cases back to the employers. There's a reason for that, and that reason is money. And so, our clients that are in work comp, in order to mitigate some of those risks and mitigate some of that, the compensable claims that come up, is we're saying, go test your employees. You pay for it, you get the results, you're entitled to those results as the employer, and then it helps you control who has access to your property. It shows that you're being proactive from a risk management perspective to look after employees, because everybody's going to argue, I got COVID at work. Okay, well, prove that you did. The reality is, prove that they didn't. That's what you're going to have to do, is prove they didn't get it at work. So just be consistent in what you do, and make sure that you get that same baseline that Duke and Davidson had, so the folks you're bringing back are COVID free. At least that your administration folks are COVID free. That gives you a line of defense that if a kid comes into a camp or a school or wherever they are, you're like, well, hey, I tested all my faculty and staff, so pretty sure we didn't get it from them. but whatever you do, just be consistent. Come up with a plan, invest in your plan, and be consistent about it. And,
now, I know,
and then we track those results for you.
okay. So I'm an employer. We've got 38 employees here at our office. We were to sit, and we have a couple people in the office, but most people working remotely at this point. And so if we were looking to bring everybody back in or whatever it might be, I would order the tests for everybody, send them to their home initially, have them do they would spit in the cup, right? Ship it off. You'd receive it in 24 hours. We'd have test results 24 hours after that. So 48 hours from the spit date. I don't know if that's the appropriate way to say it. From that date, they're going to have results, and the employee is going to have the results, and the employer is going to have the results at that point, correct?
Exactly. And you hit on a really, really good point. Whatever test you decide to do, you have to gain assurance that you're going to get those results back within 48 hours. If you don't get the results back within 48 hours, you are wasting your money and you're wasting your time. You've lost the ability to make an informed decision. So that was an issue which actually was good for us. Some of the big labs, even though we work with them, these guys are running, 10 to 14 days and getting test results back. So there's millions and millions of dollars were wasted on those tests because, remember, it's a snapshot in time is what that is.
Yeah. And a lot of the test works, the drive-in test, you go online, and those results are coming back about 5 days, depending on where you are, but 5 days. When I took my test and I had the nasal swab, I would have much rather done it into the cup. But when I had the swab, it was 11 days, I think, until I received my results. And so I really like that about MedCall, especially if you're starting from scratch. It's like, okay, it's time to bring people back. Or with schools, we're trying to bring everybody back. Let's give ourselves that baseline. We have everybody test. We say, guys, please quarantine for a couple of days, and then you know who's going to be positive and who's going to be negative. One of the questions that came up here says, you said we're entitled to the results as the employer. Do the employees need to give consent?
They
do you handle that, Randy?
We do. Each test comes with a requisition form. And at the bottom of that requisition form, the employee signs it, and he's giving consent to the employer to have access to that, access to those results.
And for our colleges and universities, you'd be doing the same thing, correct?
Absolutely. We typically there's a chief medical director on like the colleges and universities have a medical director or clinical director. We typically deliver all of the results to them.
Okay, so we've got stability, and then we've established that baseline. And then in California now, they're saying that your employees, when you bring them back for school, it should be every 2 months that everybody should be tested. What are you seeing with the colleges or the other employers that you're working with? How often are they doing the testing?
Personally, 2 months is too long. You're not going to, and like I said, I'm not trying to sell you guys tests. I'm just telling you that 2 months in between testing is too long. Duke and Davidson, they tested once a week. But when you start doing the math on testing once a week, it's tough. I mean, it's difficult to swallow that math. But again, college life is different. These kids are not going to abide by the rules, right? They're still going to slip off and to a fraternity house. They're still going to go off campus to a party or something. So testing once a week is appropriate. I'll say if you have a smaller group of folks that work with you and they're buying into your strategy, they understand the risk. If you've got 50 employees or less, like you're 38, you're telling everybody all the time, like, look, guys, be careful where you go, be careful what you do, understand what the risks are. And if you have faith in those guys, maybe test them once a month. You know, if they're,
Okay.
unless somebody's brought in and displayed symptoms. If somebody has symptoms or somebody got exposed somewhere else and they come into your office, or you have a guest come into your office and then you find out then test everybody again. I mean, the rule is the greater the risk, the more often you need to test. But I'd say once a month is probably the maximum I would go without testing, unless you just have an incredible group of folks that that you know are not going to do anything not smart.
And you're right. We had somebody in our office whose spouse received a positive diagnosis, and there have been some contacts. So we quickly ran a number of tests, had people go out and get tested, and those people have been tested and we're waiting on the results. It's been, I think, a few days since that happened. So we're working through it. You know, we're trying to figure it out. But what we also quickly did, Randy, is we quickly ordered a number of tests from you. I think it was $155. I don't want to. What's the price per test?
That's a good. I think 154, maybe 154 or 155.
Okay.
And understand what you get for that. It's the physician's order to write the test. It's the test kit. It's the shipping of the kit to your house. And it also includes an overnight FedEx return to the lab. So it really is a turnkey solution.
And if there's a positive diagnosis, then we're connecting them with the physician as well. Is that correct?
When we call them and tell them that we have their results and results are positive, we offer them the opportunity at that moment in time to speak to a doctor right away. Some folks may prefer to go to their primary care provider, but if you call your doctor's office and tell them you just got tested, you tested positive for COVID, they're probably not going to let you come. So we think it's important, especially with the other health risk factors that are in play, that it's important that you consult with a provider as quickly as possible.
And what I really appreciate about Randy and MedCall is that these aren't just doctors. These are ER docs that this is what they're dealing with all the time. They're going to be able to make a phone call. They could do a Zoom call. They could do FaceTime. I don't know if we can do FaceTime.
Well,
but we can do.
It's our own. It's our own video. It's our own video platform. It's simple and easy to use.
Okay, but you're going to be face to face with a doctor that has dealt with this before and is going to be prepared. And you're also going to be limiting the spread and the exposure that your employees have. One of the questions that comes up a lot is about insurance companies, or if it's covered under workers' compensation, or who's required. In California, if you're requiring something of your employees, you have to pay for it. You, the business owner, the employer, has to pay for it. The church or school or camp college is going to have to pay for something like this. If they have Kaiser, which like our office, we use Kaiser, you're able to bill, you have to pay for it and then seek reimbursement, but it may have to be on an individual basis. We're trying to work with some of the folks over at Kaiser to see how that would work. But you can apply for reimbursement from Kaiser on that. And it just depends, plan by plan by plan, but our benefits team, they do a great job, and they can kind of navigate the best they can through it, because there are thousands of different healthcare plans. So it's going to be different with each one of you. So we can help you navigate that from our benefits team. And I know that some are on here, so we're going to have our hands full, but that's what we're here for, such a time as this. So question came in from Valerie: can insurance be used? We can pay the co-payment. You can use insurance, but it's usually done on a reimbursement basis. MedCall is going to bill you for it first, and then you apply for reimbursement. And then most of this is, will MedCall bill the insurance companies? And that's how that would be handled.
Yeah.
I'm looking to the question. Oh, go ahead.
Well, I was going to say, for us at MedCall, we don't bill health insurance. Again, vast majority of our business is on the work comp side. So the work comp carriers or employers are covering these costs because it turns into a claim. And also because we we operate in all 50 states, which is thousands and thousands of different insurance companies. The reimbursements rates, whether they pay for a test, which test will they pay for, it's all over the board, and we're just not smart enough to figure it out. But what we can do is we can do the same thing. We can provide you with the information where you can request a claim form from your carrier or your agent, and you can go in and try for reimbursements. A lot of the labs try to offer taking insurance payments, but then what they found out is that they got so many denials from the insurance company, or maybe they pay for one, they don't pay for the second one, and so now they hold the test until they get payment. And so if you need a COVID test today, you try to get approval from your insurance company. That takes 14 days before the lab will ship you the test. So, once again, we kind of get back to that economic decision. If you need a test, do you want it today? It may just be worth $150 and try to get the reimbursement from your insurance carrier.
Yeah, I think we're really trying to avoid that next shutdown. Is the big thing here, because we've kind of gone through 2 cycles of shutdowns. We're maybe reopening at this point. Let me ask you this, Randy. We've talked a lot about colleges. We're looking at schools. What about churches specifically? If you were to have a church, and right now most churches are not meeting, or they're not gathering in person. But if you've got 100 people from that are going to be coming to a church on Sunday, are we looking at testing all of them? Are we looking at testing staff? Are we looking at, what are your thoughts on that?
Well, again, I'm not sure I'm smart enough to answer that question. I mean, at a minimum, if you're going to have your staff at the church, I mean, I think you have to test those folks. If you're, if you've got a large church, maybe you could set up a Tuesday or a Wednesday where you'd offer it at church to have your parishioners come through and just do a drive-through tent and because we have the ability to do bulk testing. So if you had 100 or 500 or 1,000 tests at any given time, allow your folks to come through and take the test. You get results back on Friday, come to church on Sunday. I mean, I'm sure the churches of all different sizes and across that's a tough one. I mean, that's a tough call.
And $155 to kind of prepay for the kit and everything, it might be worthwhile to have some on hand if you've got somebody in your congregation that you're responding to, that they had the scare, and to have those and manage that. So I wanted to make sure we answered all the questions that people had. We'll be sending information on MedCall, the program, let's see, someone said, I work at a school, students from preschool to 8th grade. Does Randy recommend testing all students as well as students prior to reopening? I think maybe all employees. Yeah.
The short answer to that is, I have an abundance of caution and doing the right thing. Sure, I test everybody, but the fact that you're preschool and 8th grade, if there's ever a one that could avoid doing it, I'm not going to recommend that. I'm recommending that you test them all. But the reality is that, the preschool and the 8th through the 8th grade is probably the lowest risk factor. But I would absolutely make sure that all of the faculty and staff got tested before those students come back. But most of those kids, if they're infected, I mean, the science right now is they're going to be asymptomatic. But they absolutely can spread the virus. So there's been a lot of conversation about that, saying kids can't give it to adults. I think that's been debunked.
Okay. Hey, let me ask you, Randy, could an individual just go to MedCall as well? If you wanted to make this resource available to the people in the church, can just an individual looking to have a COVID test contact MedCall directly?
As of tomorrow, yes. We really haven't. We haven't officially gone to a direct to consumer model. Of course, we have people that we know, friends and friends of friends all over the place call us all the time. And, we probably send out 40 or 50 individual kits to just family and friends every few days. But tomorrow we are putting up on our website where you can just go and order an individual test online, and we ship it right to your house, same way.
Okay. And so if a church wanted to make this available, they could maybe prepay for a number of them at one point to have them, like we're doing in our office, where we're having some on hand as we reevaluate and rework through our full reopening process. But if it's a church, they may want to direct people to MedCall and get it there as well.
What I would say, for a $300 donation, you get a free COVID test. You can drive to church and pick it up.
You too. Yeah, it's there. Okay. So no, I think that it's a tremendous services. We're trying to find ways. We've got so many of the schools and the preschools that are trying to reopen specifically, and it is starting to become required that employers, as part of the most recent reopening guidelines by Governor Newsom, is that everybody's tested, and this is part of that plan. So Randy, I really appreciate you and your time and just the service that you've been providing to the ministries that we serve, and I appreciate it very much. So thank you. I'll send out your information. Thank all your doctors for me, would you?
Sure.
You got a great team back there, and you guys have really responded well for us. So thank you very much for that. We'll be sending a follow-up to everybody tomorrow, probably midday. Okay.
Thank you. And if more questions come up, you guys can contact me anytime, and I'm happy to respond. All
right. Thanks, man. I appreciate it very much. Thank you, everybody, for joining us, and we'll send this out. All right. Have a safe weekend. God bless you. Appreciate it. Bye-bye.